Genicular nerve ablation does not treat the arthritis in your knee. It treats the sensory nerves that carry the pain out of it. The arthritis is unchanged. What changes is whether the signal reaches you. Genicular nerve radiofrequency ablation treats knee osteoarthritis pain by interrupting the sensory nerves that carry it, rather than by altering the joint. Several randomized controlled trials have demonstrated its superiority over intra-articular steroid, viscosupplementation, and oral analgesics. That comparison matters because those three are usually what has already been tried by the time anyone raises ablation. So let me start with what is actually being targeted. The genicular nerves are sensory branches supplying the knee capsule. Ablating them reduces the pain signal without touching cartilage, ligament, or bone. Nothing structural inside the joint is altered. The arthritis is unchanged, but its transmission is interrupted. I want to be clear about this with patients because it is the part that most often gets blurred. This is a pain treatment. It is not a joint treatment. It does not restore cartilage, and it does not reverse the underlying osteoarthritis. If anyone describes it to you as fixing the joint, that is not what the evidence describes. What it can do is interrupt the pain that the joint is generating, while the joint itself stays exactly as it was. Now, the technique has a genuine open question inside it, and it is worth understanding before you consent to anything. Cadaveric studies demonstrate significant variability in the location of the genicular nerves. That variability has stimulated debate about the ideal target locations for ablation. It is a technique that has to account for the fact that your nerves may not sit exactly where the textbook drawing puts them. In plain terms, the anatomy here is not uniform from person to person, so this is not a matter of hitting fixed coordinates on a map. Despite that variability, favorable outcomes have been observed in studies targeting only the superior medial, inferior medial, and superior lateral genicular nerves. Those are the three that the favorable outcome data sit behind. Targeting additional sensory nerves may further improve treatment success, but that remains an open question rather than settled practice. I would rather tell you where the honest edge of the evidence is than pretend the whole map is filled in. Here is how it compares with what you have probably already tried. Genicular ablation of those three nerves appears to be an effective treatment for painful knee osteoarthritis. The randomized evidence showing superiority over intra-articular steroid injection, viscosupplementation, and oral analgesics is the practical argument for considering it when those approaches have not held. Viscosupplementation and the ablation itself are both described on our treatment pages, so you can read the comparison in detail rather than taking it from a video. Before the ablation, though, there is a step that I consider non-negotiable. Ablation is generally preceded by a diagnostic genicular nerve block, which anesthetizes the same nerves temporarily. It is a test of the target. If the block does not relieve your pain, then ablating those same nerves is unlikely to relieve it either. That is precisely the information worth having before committing to a longer-lasting procedure. A temporary answer first, then a durable one only if the temporary answer was yes. The nerves are located with image guidance, and ultrasound-guided and fluoroscopic procedures are described on our treatment pages as well. On safety, let me state it the way the evidence states it. Genicular ablation appears relatively safe on the basis of available data, but the authors of the current evidence review are explicit that additional large-scale studies are needed to provide greater confidence. That is a fair summary to carry into a decision, encouraging evidence, not a closed question. Anyone who tells you the safety question is fully settled is going further than the literature does. So the shape of the decision is this. You have a painful osteoarthritic knee. Steroid, gel injection, and oral medication have not held. A diagnostic block tells you whether the pain is traveling through nerves that can be interrupted. If it is, ablation is a reasonable next conversation with the honest caveats attached. And the caveats are worth repeating one last time, because they are what makes the conversation an honest one. The arthritis stays where it is. The evidence for the three named nerve targets is favorable, the ideal target sites are still debated, and the safety data are encouraging while the authors themselves ask for larger studies. That is the whole picture, and it is the picture I would want if the knee were mine. Seek urgent assessment if you experience a hot, swollen red knee with fever or chills, or a sudden inability to bear weight. Call 911 for calf swelling, redness, or tenderness. especially with new shortness of breath or chest pain. Monitor for spreading redness at injection sites or new numbness and coldness in the foot below the knee. Visit our appointment page or contact the Padda Institute today to discuss your interventional pain management options.